Hi, good evening. You're with me, Jasmine Obaka, and this is Agenda AWANI. And today is a special day for all women out there and also for men who are trying to get a baby or wanting to get more babies. So today I have a special guest with me. I'm going to share with you later who it is. He is from the TMC Fertility Center in Kota Damansara. But I want to also share with you, when you're hoping to make a baby and wondering about your chances at advanced maternal age. When we talk about advanced maternal age, it's the medical term of women who wants to get pregnant at the age of 35 and later. So age is definitely one of the key factors that predict your ability to conceive. However, other, I would say, key factors are also contributing to that. So we'll ask him later on what it is about, and studies show your fertility starts to decline at the age of 30 and keeps on dropping steadily until you hit menopause. However, it's not only possible to deliver a healthy baby after age 35 because it's actually quite common. So today, Dr. Navdeep Singh, consultant obstetrician and gynaecologist, also a fertility specialist, like I said, from TMC Fertility Center, is here to share with us his insights on questions surrounding fertility especially. So the first question that I want to ask you, Dr. Navdeep, is chances of getting pregnant decreases as women age, as I was mentioning just now. And the risk of having an unhealthy baby increases as well.
Correct.
So can we tell the viewers out there more or less why that happens and why are the chances of a baby being born unhealthy increases as well?
Well, women are born with a certain number of eggs, and the first time they hit their menstrual period, their menarche, they have about 2,000 to 3,000 eggs. And as they get older and older, they tend to lose their best eggs. Okay, so when they reach age of 35, 37 years of age, they have about 15 to 25,000 eggs left. Okay, and when it crosses up to age of 40 and above, then all their best eggs would have been lost already. So the ones that are left are generally the ones which are not very healthy. Okay, so the risk of having a Down syndrome child, for example, is 1 in 100. That's only about 1%. And for us in the medical fertility, that's high enough.
And are those the questions that are usually asked when you, because the first thing you mentioned was Down syndrome, for example. Are those the common questions that are asked by patients?
Yes, definitely. A lot of patients are a bit worried about that because as I mentioned, the risk is about 1%. So even if they get pregnant naturally, they would insist on certain tests to be done on them to ascertain whether the baby is healthy or not, which is by scans and even through blood tests. Okay, so which we can determine quite accurately, okay, whether the baby is affected or not.
Yep.
However, 99% of them would be fine.
No.
Okay, and in terms of fertility treatments, we prefer the patients to be of younger age group because the successes is much higher. Because they got much more, the number of eggs and the quality of the eggs being much better.
Yep.
Okay. However, due to this current scenario in our lifestyles, career-minded women, you know, they tend to delay their childbirths, okay, to a later age. Hence, currently we are seeing quite a number of patients which are above age of 35. But don't despair. The treatments out there, we have quite good type of treatment protocols which are available, which we can help these women achieve their dream of getting a baby.
So talking about chances of getting a baby and age increasing and all that, we also want to talk about things like when a couple comes in and they've been married, say, a couple of years and they've been wanting a baby and they tell you like, let's run some tests. Then like say they come out with infertile, they say. So what are the treatments that are given to these couples? Because a lot of stigma talks about, when we talk about infertility, it's only women. But now we also want to talk about how men are also decided to be infertile, for example. So what are the treatments offered?
Well, firstly, it takes two hands to clap. So both men and women have to be checked at the same time.
Yeah.
Before we discuss the treatment options, there are a few things that we do to determine the type of treatments which we can offer the patient. Because most importantly, all the patients are different.
Correct.
So we need to individualize the treatment between patient to patient. So there are four main things that we check in a couple when they first come in for a consultation. First is husband's sperm analysis. 3 to 5 days after abstinence is the best time for us to ascertain whether his sperm quality is adequate or not. There are few aspects of the sperm test. One is the concentration, the number of sperms that he has. Secondly, the motility, the sperms which are moving. Okay. Thirdly is what we call morphology. Morphology is the normal shape and size of the sperms. So all these things are important. Secondly, for women, we will do a transvaginal ultrasound scan to determine whether the womb is normal, and then we'll assess the ovaries. We look for things like the antral follicle counts. Antral follicle counts is basically a test of ovarian reserve where we can determine whether she has enough eggs or not. Okay, and the other things too, like fibroids or ovarian cysts or certain abnormalities which need to be surgically corrected before we start the fertility treatment for the patient. Thirdly is the fallopian tubes. Fallopian tubes is the bridge between the sperm and the eggs. Okay, that's where the eggs are fertilized and subsequently are pushed into the womb. So the fallopian tubes are blocked. There's no way the lady can conceive naturally. So we have to address that by ways of doing a hysterosalpingogram, X-ray, or there's another procedure called a salinogram where we inject fluid into the fallopian tubes to see whether or not the fluid flows out nicely. And thirdly, you have the laparoscopic surgery where we give them anesthesia and we put in cameras into the tummy to assess the womb and the fallopian tubes. Okay. Finally, those patients who are of the older age group or have irregular cycles, we have to do their hormonal assessments. Okay, where the hormonal test will guide us as to whether the patient has other medical problems we need to be sorted out first. Example, thyroid problems, diabetes, prolactin issues. Yeah. So by treating those things itself, you can enhance or rather improve her chances to conceive. And the other test, it's quite important, is the anti-Mullerian hormone. That is the best test to ascertain the patient's her ovarian reserve. Okay, that also will guide us as to how much of injections do they need to stimulate their eggs.
So when all these tests are done, say for women and all that, then they will ask you questions like, if my chances are low, what is my next step? And obviously IVF is, I wouldn't say the first thing that come up through their head. So it's maybe is a suggestion that was given to them. So some people would know IVF is a very common thing now, currently, compared to 10 years back maybe. So maybe those who do not know what IVF is about, roughly can you tell us what is IVF?
IVF used to be known as test tube babies. Okay, it's a treatment of choice for certain couples where they have been trying for many years, or they have a certain problem like blocked tubes, or the husband has very poor sperm quality. Okay, it's where on the first there are a number of protocols available. The ones which we commonly use is the one where we start the injections, the hormonal injections, on the second day of the menstrual cycle. Okay. And the injections go on for about 10 days. During these 10 days, 2 or 3 times the patient has come into the hospital to get herself examined, okay, where we do the transvaginal ultrasound scan to assess the ovarian response, the number of what we call as follicles, okay, so the eggs. So once the eggs reach a nice size, which is more than 17 mm and above, more the merrier. We prefer at least about 5, 10, sometimes we go up to 15, okay, eggs. Then once it reaches a good size, then the 13th day we'll do a transvaginal procedure where we retrieve her eggs, okay, oocyte retrievals, and that will be done under anesthesia. 3 to 5 days later, okay, once these embryos have been fertilized, 3 to 5 days later, we'll transfer it back into her womb.
And how many embryos? I mean, how many of them? A lot?
Well, we prefer to transfer 1 or maximum 2. Because when you transfer 1 embryo in, the woman gets pregnant, okay, and she'll be like a healthy, normal pregnant woman, okay, compared to twins or triplets. A lot of people feel that buy 1 get 2 free, okay, triplets. But everybody sees the patient after the delivery. Once the babies are out, everything's happy and nice. But you don't know what happened before that.
Yep.
Okay, where risk of preterm deliveries, medical illnesses in pregnancy, she's unable to move around normally, her pregnancy risk is high. So patients who come in to a fertility clinic are generally healthy. So we would not want to make them unhealthy.
Correct.
Okay, so in my practice, I prefer to put in 1, that's my first choice, or 2. That's it, no more 3.
And when you put in the embryos prior to that, can it be screened?
Yes, we do have certain methods available to screen these embryos. Firstly, by microscopic assessment of the embryos. We have a certain criteria to grade the embryos, whether it's grade 1, grade 1, 2, 3 to 5. Okay? Only grade 1, 2 and 3 are good for transfer. 4 and 5 generally they're discarded, okay, because the probability for a pregnancy is very low. Okay. Secondly, the other method is known as pre-implantation genetic testing. During this process, before we transfer it into the womb, we will do a procedure called a biopsy, where we will retrieve a few cells, 2 or 3 cells, okay, from the embryos. And then we will assess them under certain testing, okay, and we can determine exactly how the chromosomes are. Okay, we can rule out Down syndrome, Patau syndrome, trisomies.
This is before?
Before transfer. Okay, so you'll know all the 23 pairs of chromosomes, which 22 pairs, and the X and Y chromosome, which is the chromosome that determines gender. Okay, so when we do this test, we can determine it can help us to identify the best embryo to transfer. So these procedures will reduce your risk of miscarriages, will improve the probability for pregnancy, okay, and also assure you that your baby is healthy.
Okay. I want to talk to you more about types of the PGTs, which is the pre-implantation genetic testing that we were talking about in a bit. We'll be right back. Don't go away.
Okay.
Hi, you're back with me on Agenda Awani with me, Jasmine Awabakar, and today I have Dr. Navdeep Singh from TMC Fertility Centre, Kota Damansara. Exciting and also interesting and informative information about IVF, about chances of you getting pregnant, and what are the ways and also things that you can do and treatments you can get from one of the renowned fertility centres in Malaysia, TMC Fertility Centre. So we're going to continue our conversation about the pre-implantation genetic testing. Just now we did mention about how the embryos are checked prior to transferring into the womb. And we also want to know the types of PGT, that's a short form of the pre-implantation genetic testing, so that you are not lost in this conversation. So, Doctor.
There are 4 main types. The commonest is the PGT-A for aneuploidy. It's a test where we determine the numbers of chromosomes to ensure that the embryo has 23 pairs of chromosomes. Okay? Any addition, known as trisomy, or any deletion, then that will, addition or deletion of the number of chromosomes will reduce your probability of pregnancy, and also it indicates that the embryos are unhealthy. Okay? And that's the commonest method that we use in patients who have recurrent miscarriages or recurrent IVF failures, and those of the advanced maternal age, they're worried about having like a Down syndrome child, okay, or those families which have had abnormal child before. Right. The second type is is known as PGT-M for monogenic diseases. It's where we can determine whether the embryos have any inheritable diseases that the family already has. Example, thalassemia, okay, or cystic fibrosis. Okay. Well, we will examine both the couple, husband and wife. We will check their blood for any mutation of that particular disease, and then we can determine exactly what mutation they have. Okay? And then we can do a biopsy and a test on those embryos to rule out whether they have that disease or not. So much so that when we transfer an embryo in her womb, we are very sure that that embryo does not carry that disease which runs in their family. Okay, so she'll deliver a healthy baby.
Healthy baby.
The third method is known as PGT-HLA, human leukocyte antigen. Generally is used to determine whether the embryo, okay, matches another sibling of the family. Okay, any family member, usually the sibling. So it can be used as a savior sibling. Example, if the family has a child, it has bone marrow problems or blood problems, okay, and needs a bone marrow transplant. Okay, so the family can do PGT-HLA to determine whether that embryo is compatible with its sibling. Okay, and then the mother can deliver that baby, and that sibling can be, the blood can be used to save the elder sibling. Okay, no, it's a savior sibling. Okay, and finally is the PGT-SR for structural rearrangement. This is also generally done to ascertain whether the embryos are healthy or not in certain couples, but it's not very commonly used compared to the other two, which is the monogenic and which is the aneuploidy testing.
So we talked about family inheritance or inheritance. Well, say for example, I do not have any family history of chromosome conditions. Is PGT still, appropriate for me?
Yes, must have an indication. You may have patients who had recurrent miscarriages, recurrent IVF failures, or above age of 40, advanced age group, okay, or maybe history of Down syndrome child before. Yes, it's definitely indicated.
And of course, chances of success in PGTs.
Okay. My last cases, okay, out of 10, 8 of them are currently pregnant. Okay, so you can see that the embryo selection, okay, it's enhanced because we can select the best embryo to be transferred. Okay, so the success rate is very good. I would say definitely above 70%.
When we talk about 70% and 8 out of 10 is pregnant, risk. Those are questions that are common, I'm sure, because a lot of people are aware of, they have Google, Dr. Google, Dr. Friends, for example. So they would want to know about risks. So can we talk about risks?
The biggest risk for doing a pre-implantation genetic testing is having all abnormal embryos. Hence, there's nothing to transfer. And that can happen in a certain number of patients. Example, we had a patient with 6 good-looking embryos. When we did the genetic testing for them, all had abnormalities. So in those kind of scenarios, it's very heartbreaking for us as in the medical side and also for the patients. There is nothing to transfer. But in certain scenarios, either the husband or the wife had some genetic problem. Okay, where we have to do a karyotyping. That means a genetic testing for either the husband or wife. We do it for both to look to check whether they have any abnormalities or not, which predisposed to that condition.
And usually, if they were to go through such ordeals, for example, I'm sure you've gone through a few from your patients yourself. So, I mean, what do we actually, do they normally do it again, a whole round again?
Yes.
They do?
Yes. Quite a number of patients repeat the whole IVF cycle, and we take the injections for about 10 days, retrieve their eggs, and then we do the biopsy and wait for the results. Some of them eventually become successful in getting their healthy embryo and eventually get pregnant, but some of them still remain the same. You know,
Okay.
it's heart-wrenching, yes.
Yeah, I know. I'm guessing it'll be heart-wrenching to those couples as well.
Yes.
Let's a little bit touch on openness of people about treatments like this now, currently, because we are in the area of Malaysia Baru, so a lot of people are slightly more open to talk about things like this. So what do you think about acceptance of the people out there about IVF and talking about fertility itself?
I think our the citizens of Malaysia, okay, a lot of us are educated nowadays. Okay, everyone goes through education. Everyone's aware of what we have out there nowadays, and social media helps a lot too. Okay, a lot of doctors are against Google, but I feel Google is good because it educates to some extent. Okay, our general public as to what kind of treatments are available. You know, so it's good. It's good that everybody is aware now. So at least they will come in for treatment at the earlier stage, rather than being unaware and coming age of 45 and then trying to seek for medical advice. So it's good that we have quite an educated population nowadays.
Yeah, I would assume so, because nowadays when we talk about fertility and we read, everybody is open to sharing their experience, etc. So talking about fertility centres that TMC has, not only in Kota Damansara, if I'm not mistaken, do you have any more fertility centres around Malaysia?
Yes, we have a branch in Penang, Ipoh, Kepong, Puchong, okay, and Johor Bahru. Okay,
It covers the big cities.
Yes, covers mainly big cities. Yes.
And the treatment offers are the same?
The treatment offers can vary between centre to centre. Some of the centres have certain like genetic testing, some don't. But we do offer a wide range of treatments in those centres too.
And let me tell you a little bit of a personal. I go to TMC Fertility Centre for my kids and myself as well a couple of years back. So I know they have a very good offering, I would say. So for you out there, don't worry, come in. They'll give you the best information that you need, not necessarily act on it. However, the information that you get from TMC Fertility Centre is the best way to go, because only Dr. Google would not help.
Yes.
We have experts to talk about things like this, and clearly today I've learned a lot, and I'm sure you did as well. Thank you very much, Dr. Navdeep, for being with us on Agenda Awani. We'll call him again, hopefully, to extend this conversation, because only talking about it once would not let people know more about fertility, about being fertile, for example. So thank you very much for joining us, Dr. Navdeep. Thank you very much. I'll see you again soon, and this is Agenda Awani. I'm Jasmine Obaka.
Thank you.